Welcome, everyone. It is a true pleasure and an honor to introduce Dr. Lonnie Zwaigenbaum, who, despite the fact that he looks younger than me, he is actually a mentor. I remember 20 years ago when I joined McMaster University, Lonnie was one of my mentors, and I still consider him to this day a close colleague, friend, but also a mentor. So Dr. Zwaigenbaum is a developmental pediatrician at the Glen Rose Rehabilitation Hospital, where he directs the Autism Research Center. He completed his clinical training in Toronto and research training at McMaster here in Hamilton, where he worked prior to moving to Edmonton in 2006. He is currently a professor in the Department of Pediatrics at the University of Alberta and is supported by the Stollery Children's Hospital Foundation Chair in Autism. Now, there's a very long list of titles and positions that Dr. Zwaigenbaum holds, but I will simply mention that most recently, Dr. Zwaigenbaum served as the chair of the oversight panel of the Canadian Academy of Health Sciences, and this was a tremendous collaboration that led to the writing of the report Autism in Canada, Considerations for Future Public Policy Development. And as many of you know, this is the report that is guiding the efforts of the Public Health Agency of Canada and the federal government for the creation of the National Autism Strategy. So in short, Dr. Zwaigenbaum is one of the most influential clinician scientists that we have in Canada, but is also globally recognized and respected for his contributions to the autism community. Lonnie, welcome, and the floor is yours.
Great. Thanks so much, Stelios. That was a very, very kind introduction. The topic today, I think, is certainly something close to my heart, and I think something that we all grapple with, and that is like how to make sure that that children with autism or autistic kids, and frankly, autistic people across the lifespan are receiving appropriate healthcare. And what does that look like in the community in terms of partnerships among specialists and GPs and in the primary care system? So that is the topic. I do receive research funding. I don't have industry funding. So just as a general acknowledgement, I'm really delighted to be working as part of the PARC team that Stelios is leading. And it's been amazing working with a new community of families and clinicians through this research and thinking about how to grapple with kind of health systems issues related to autism care more generally. So just to start, Stelios gave a bit of my bio. So here's like baby Lonnie in first year medical school. And I wanted to show this picture just to highlight sort of how, to what extent sort of our perspectives around healthcare for autistic people have changed since the 80s and 90s. Now, it's a work in progress. So first of all, I have to acknowledge, I'm not quite sure what was going on to generate that facial expression. Maybe I was thinking about sort of all these important issues we'd all be working through in the future. There are a lot of physicians and other healthcare providers who trained around the same time I did. So I think to the degree to which the perspectives have changed, I think is quite variable. And this is very much a work in progress. But in the 80s and 90s, autism was regarded as a rare condition. Our colleagues, Susan Bryson and Isabel Smith, published the first study on rates of autism in Canada in Nova Scotia. And at that point, the rate was around 1 in 1,000. I remember like very specifically as a first year resident in Kingston, doing our rounds of the kids that were admitted to the hospital and being pulled aside by the supervising pediatrician who pointed out this little guy who was showing a lot of features of autism. And he said, you know, you see the little boy who's having trouble expressing himself and flapping his hands. You know, so he has autism, and it's a very rare condition. You might want to spend some time kind of speaking with the child and speaking with his family later, because, you know, it's rare and it may be the only child with autism that you see in your entire career. So obviously things have changed quite considerably, but that was certainly the prevailing view. And not only was it viewed as a rare condition, but it was that the medical support for it was largely viewed in relation to kind of treating autism. This group of individuals was largely seen through specialty clinics. I think community physicians had somewhat less of a role at that point. Their role, certainly in assessment, was largely about watching for early signs and then referring into specialty centers. And again, the condition was largely viewed as a diagnosis to be treated, with a focus on the behavioral features and largely a focus on early childhood. So it's a bit of an ivory tower approach, kind of very siloed, and sort of the kind of medical approach we take for kids with rare conditions, that they would receive a lot of their care within a specialty clinic, and often community physicians kind of view themselves as not really being well equipped to provide healthcare to the group of kids. Now, fast forward to 2024, the current estimate of rates is about 2%, or 1 in 50, based on a recent Stats Canada survey. And there's no question that the number of specialists in the area have not kept pace with the increased rates. I mean, we're fortunate that since my training, and like some of the real kind of pioneers in the area, like Peter Zatmari and Susan Bryson and Wendy Roberts, like there's certainly a larger cohort of a range of health professionals, psychologists, speech and language pathologists, pediatricians, psychiatrists who work in the area. But we've sort of kind of ticked along in terms of our numbers, certainly not at the pace of the actual rates of autism. I think there has been a recognition that this is not simply about a diagnosis from the perspective of healthcare, but it's a population of people who need healthcare like other Canadians. As well, this is not just a condition that we need to focus on in childhood, but autistic children grow up to be autistic adults and achieve great things, and along the way continue to need healthcare. It's a bit naive for me to present this as like things have completely changed. I think there are probably a lot of professionals whose perspectives on autism are probably more similar to that view in the 80s and 90s than now. We're making some progress, but I think these are issues that we need to continue to grapple with. But I think where we're heading is, rather than thinking about this ivory tower approach, to really be thinking about autistic people as needing healthcare and needing a medical home that kind of coordinates their healthcare needs, that provides monitoring over time for emerging physical and mental health, and takes more of that holistic approach that takes account of the child and family and their broader community, and thinks about health, not just this kind of treatment of like symptoms and disease, but rather like preventative healthcare, and wellness and engagement in community, and again, sort of this broader perspective of health and functioning that I think is the norm for all Canadians, and there's no reason that it shouldn't be for autistic people as well. And from that perspective, community physicians have a lot of really important roles in supporting the health of autistic people. Certainly, community physicians. So, and I should say that this guy in the center is Dr. Hasu Rajani. So he's this lovely community pediatrician in Edmonton. He's actually the lead for general and community pediatrics, and he's one of a number of pediatricians that's very passionate about neurodiversity and providing assessment and ongoing healthcare to kids with autism and kids with a broader range of developmental needs. And his role is not limited to sort of the traditional role of kind of like early detection and referral. He is part of a group that is very aware of the early signs, but some of those pediatricians have actually done some training that allows them to take an advanced practice role in assessment and diagnosis, which I'll talk about a bit further, which I think has been really essential to trying to keep up with the number of children and increasingly sort of older individuals that need to be seen. Certainly as a pediatrician and other community physicians, he has an important role in terms of management of physical and emotional health, both monitoring for the emergence and actually sort of taking a direct role of monitoring. And as a pediatrician, I think that he plays an essential role in kind of providing that bridge between specialty care and primary care. So a lot of pediatricians have more of a consulting role than sort of like doing regular checkups as a primary care physician. I think that we recognize that there's a bit of a tension because pediatricians are often, they have advanced training, they may be particularly knowledgeable, and there's a certain quality of care and comfort that's provided to autistic kids. There's a risk, of course, course, for pediatricians providing primary care, like sort of the regular checkups, and not engaging family practitioners along the way, because of course, when kids hit 18, they don't see their pediatrician anymore. So there's this kind of, sort of very abrupt need to make a transition to a family physician. Whereas, of course, if there was a family physician involved at the outset, they could work in partnership with pediatricians, but of course, get to know the child and family along the way, and there would be sort of greater continuity as that individual reached their adult years. So that is something that we're working towards. So in terms of like the talk, what I'll talk about specifically is how community physicians, including pediatricians, can be supported in actually having an advanced practice role in diagnosis. More broadly, how to address the healthcare needs of autistic kids and ultimately autistic people around physical health and emotional health. And just sort of what is the strategy? Like, how do we actually create these partnerships and communities of practice among various healthcare providers? So, as a pediatrician, I'm kind of coming in with this narrow view around physicians, but truthfully, I think that the kinds of principles and strategies that we're talking about today, I think apply to the broader kind of professional community that provides supports and care to individuals on the spectrum. So some of what I'll be saying is kind of anchored in recommendations that are part of practice statements that were issued by the Canadian Pediatric Society in 2019. I was part of a working group that included representation from a number of professional societies, as well as the Autism Alliance of Canada and other parent partners. The three areas of focus included early detection, kind of models of diagnostic assessment, and then ongoing healthcare. I won't talk a lot about early detection today. It's been an interesting process for me because it's where my kind of personal research has focused over the years. And we certainly made a lot of important progress in terms of learning about early signs. And some of the key messages from the Canadian Pediatric Society were that all Canadian children should be monitored for early signs of autism as part of general developmental surveillance, and by a range of professionals. And whether that's the family physician, whether that's the public health nurse providing the kind of vaccinations as they do in some provinces, including Alberta, whether it's the audiologist who's asked to see children for a hearing test, and certainly in the broader sort of kind of educational developmental health system. And certainly we see a lot of kids where they're flagged because they have a really knowledgeable early childhood educator who becomes sort of the individual that sort of brings the family into the system. And there's a recommendation around children who are identified as having a higher likelihood of autism receiving an early focused evaluation to determine the need for further assessment. It's not quite recommending screening as is in the US and some other areas, but rather kind of an ongoing process of monitoring using sort of the best possible tools that we have. But I think that it's not quite enough. I think that the work that's been done around learning about early signs has increased knowledge among the healthcare community, and and on an individual basis, certainly we see some kids being referred younger, but I think that strategy kind of assumes that if we just identify the earlier signs, we can make the diagnoses at an earlier stage. It doesn't seem to be the way that things are playing out. The age of diagnosis of autism in Canada and other areas of the world hasn't really shifted all that much over the past 10 or 20 years, despite this increased knowledge. I think that part of the challenge is that whereas perhaps in the past recognition of early signs was kind of the barrier to early diagnosis, at this point we recognize there are a lot of other bottlenecks in the system, not the least of which is that we just don't have the system capacity to kind of keep up with the number of kids who are being referred for assessment. So waiting lists get longer and longer, and families are having to deal with this kind of distress of knowing that there's a need for further assessment, knowing that there's a need for accessing additional services, and not being able to access a diagnostic assessment. So we need to address this issue more directly. And there is now a lot of work both in clinical settings and also kind of academically, both including at a health system level, to really think about how do we actually change the way we operate. How does the system resource assessments and who is involved in diagnosis? And maybe through these community partnerships, we can actually make sure that more kids can be seen and that we can provide more timely access and also access that's kind of further integrated into the community and sort of involves people that the child and family already have a relationship with. Um, this is not an idea that has been universally embraced in the field. I think there's been a bit of a tension between sort of wanting to increase capacity and the concerns about sort of potentially diluting the quality of assessment as we engage kind of more people in the diagnosis, including community physicians. This is a commentary that I wrote with a colleague, Zach Warren, kind of ironically, just kind of as the pandemic was starting to ramp up. And I think one of the silver linings in the pandemic is it exposed some of the gaps in our system and certainly the lack of kind of reserve to kind of deal with disruption like we've seen through the pandemic. And I think what it's led to is sort of greater openness to try things differently, to think about sort of more creative strategies around building capacity for diagnosis, and also thinking about being a bit more flexible in terms of what is best practice in diagnosis, and when we think about gold standard, like what are the critical elements, what really is essential. So that takes us to kind of where the stance of the community, the Canadian Pediatric Society, and it's a process that I was involved in, and a number of amazing people, including some people on the line today. This particular statement was led by Jessica Bryan, who many of you know is a clinician scientist in Toronto. And this is also kind of work that I think is a kind of a question that I think many of us, including many of you, have been reflecting on for many years. Like, what is a gold standard autism diagnosis? So the key elements really are, having a confident diagnosis that's well informed by the information that we gather, talking to families, spending time with the kids, gathering information from other people who know the children, like the child care providers and the educators, and assessing for diagnosis, but also kind of the strengths and particular challenges to be able to take that individualized approach that Stelios referred to. Identifying co-occurring health and emotional health conditions, ensuring that there's discussion of the diagnosis in a way that's sensitive to the family's needs and priorities, that's compassionate, and ultimately emphasizes strengths, hope, and empowerment for families. And that part of that empowerment is making sure that there's practical information about accessing supports and services, and that it is done in a way that considers the needs of the child and family and their preferences, that's done in a culturally safe way, and that's done in a timely and responsive way. So none of that really specifies kind of what type of professional it needs to be. I think that the norm currently is that diagnosis is done often by teams, generally led by a clinical psychologist, developmental pediatrician, or child psychiatrist. But there are certainly other groups that have this within their scope of practice, including community pediatricians, to be honest, including nurse practitioners who have sort of a kind of area of kind of focused and advanced training. And again, I think this is what we need to grapple with. I mean, interestingly, these principles do not actually necessarily imply the need for particular measurements. So I think another contentious issue is the degree to which there needs to be specific measures that are involved in all diagnosis. For instance, the Autism Diagnostic Observation Schedule, which is this amazing interactive tool which generates really high quality information that lets us kind of get to know the kids, but of course is also a bit time consuming and may lead to some restriction of who's involved in diagnosis because of the need for kind of specific training and experience on that tool. So the recommendations of the the Canadian Pediatric Society, we're really thinking about multiple pathways to diagnosis, the traditional specialty pathway, kind of multidisciplinary team assessment, but also a potential community model. And this doesn't need to be dichotomous. I mean, there are teams who work in community, sometimes led by the types of specialists that lead assessments in specialty centers, but sometimes can be led by a community physician, community pediatrician, or another community psychologist. There are community pediatricians who are been demonstrated that they're able to do this kind of assessment in their own office practices, kind of supported by community assessments like from a speech and language pathologist that may not occur sort of in as coordinated and synchronous way, but where the information is available to the diagnostician to inform their assessment. And then the critical thing is that this isn't intended to be siloed. You know, the children where there's less complexity identified at the outset can be designated for community assessment, but those community pediatricians can work in partnership with the specialty teams. There's an opportunity for ongoing support and mentorship to talk about kids that they're seeing and for referring kids that they're uncertain about. So this isn't about locking children into particular pathways, but on the other hand, really sort of taking advantage of the strengths and expertise sort of in the community to build more capacity. There's been a fair bit of work done in this area. Melanie Penner, who's an amazing colleague in Toronto, who's led a lot of this work together with another colleague, Mengshuang Lai, wrote a commentary on this just last year, reviewing the literature and pointing out that involving community pediatricians in diagnostic assessment, kind of leading assessment within their own offices, is an effective way to build assessment capacity. Reviewing the data, Mel observed that ruling out autism may require more expertise than ruling in. So the idea that kids who, for instance, have more subtle features or less significant developmental delays or stronger language skills may have a more subtle presentation, and it may be more difficult in a community setting to be certain about whether the diagnosis is or isn't present, and those may be the kinds of kids that need an additional opinion or perhaps starting in a specialty center, but not invariably. I think in addressing the concerns about what's potentially lost in a multidisciplinary assessment, Mel talks about a lifespan approach or a just-in-time approach where, for instance, even if a cognitive or kind of IQ test isn't part of the initial diagnostic assessment, additional developmental assessment can be done kind of at a time where specific services are being planned. And in fact, the information may be more timely or relevant at that stage as well. In Edmonton, we've had kind of a three-step training process for pediatricians who've wanted to take an advanced practice role, kind of initial training, either in person or online, kind of fairly traditional approach of reviewing the details of the diagnosis, how to go about an interactive assessment. And we kind of have a scaled back version of the ADOS that is kind of a bit more suitable for pediatricians to use in their office. Then a colleague and I have actually gone to the physicians' offices to actually be by their side and give them a bit of coaching in the moment as they're seeing sort of the initial few kids on their own. And then they have, then they become part of a community of practice and present the kids that they're seeing to their colleagues, as well as a couple of us at the Glenrose. And as part of that, to be able to sort of talk through some of the uncertainties and kind of refine their own kind of thinking around diagnosis so that they can work independently and start to see kids where the presentations may be less straightforward. So it's a continuous process to kind of build that capacity and partnership. And it's supported by a particular continuing education model that I'll speak a bit in more detail called Echo Autism. And I just want to acknowledge the partnership with the Canadian Autism, the Autism Alliance of Canada, and particularly Deepa Singhal, who's particularly passionate about this area, and really excited to be working with her to think about how to kind of spread and scale this kind of capacity building approach across the country. And I'm also very excited to be part of a research network led by Melanie Penner, where she and a team are systematically evaluating this kind of training model to see, whether it's effective and sort of what the experience is like for families as well as the clinicians. So, I don't want to oversimplify sort of like what it's like to get something like this off the ground. As you know, pediatricians are a busy group. Really, any professional group who doesn't already already have this as part of their scope of practice, they might hesitate to think about taking it on because it does require some commitment around the training, and then it's pretty it's pretty demanding and time intensive work. So so a lot of our focus has been thinking about how do we make this doable for the pediatricians? Like, how do you actually successfully add this to a busy office practice? So the assessment may need to look a little bit different than it looks like in our specialty clinics. Practically, they may need to sort of break down the assessment into 2 or 3 visits, and it needs to be done in a way that that they can kind of manage it in terms of their time demands. What we found is having a colleague, so for example, one of the nurses in the office, do some file review and pre-populate a report has actually been really helpful in terms of kind of streamlining the process, and certainly making sure that they have access to information about supports and services so that they can communicate that to families, and so they're not having to kind of pull that together on their own has also been helpful. I'll also flag that these kinds of initiatives have mostly been limited to preschoolers, so thinking about how we extend this to older kids, and also, kids that have a somewhat less straightforward presentation, but where an experienced pediatrician should still be able to kind of take on the responsibility of diagnostic assessment. So, so it's an effective model, but again, how do we scale it up so it actually starts to allow us to chip away at the large number of people that need to be seen for diagnosis? And I've alluded to this, but some of the practical issues are making sure that report templates are made available to these community clinicians, that no one group has kind of a monopoly, or or kind of information about resources that isn't being appropriately shared. So practically, that may need to be a community conversation about kind of who holds that responsibility. Is it in a clinic? Is it through one of the autism societies? Autism Edmonton, for example, for us has been a terrific partner, and they have an amazing website. And so working in partnership with an organization like that to make sure that access to information about navigating the system is easily accessible. And then also in-person and online support groups, making sure that families can access those kinds of supports regardless of whether obtaining the diagnosis. And then I mentioned this community of practice or continuing education support. And I think that is actually really important in thinking about diagnosis as well as the ongoing medical management. So I'll briefly talk about sort of healthcare, because that's obviously a big part of the discussion topic today. Like, this isn't only about diagnosis. When we think about healthcare, truthfully, we're thinking about kids coming in for their checkups to make sure that that they're being monitored for sort of other, kind of health and emotional health. It's important to recognize that that autistic kids have higher rates of physical and emotional health conditions. As I'll comment, the kind of healthcare and the management strategies are probably similar largely to kids who don't have autism, but it I think historically it's been difficult for families who have that includes some on the spectrum to access primary care and to receive timely support and assessment for these common health conditions. And there's a higher proportion of autistic kids who end up getting their kind of ongoing health care through the emergency room, through walk-in clinics, because they've had a hard time finding a family doctor. Again, I really want to emphasize the key principles that most physical health conditions, although they are more common, there is a general approach to assessment and management that applies pretty universally, and community physicians have the relevant expertise. I find when I'm working with my community colleagues, often it's more about providing reassurance and sort of reminding them that they can work in partnership with families. Like, kind of families will help provide that bridge when there are communication barriers or they're having trouble with assessment, because the way the child engages and communicates is a bit different than some of the other patients. But at the same time, reminding them that they know how to manage sleep, they know how to manage constipation, and that that they are like really essential partners and providers in terms of addressing these issues. Again, as Stelios alluded to, all healthcare is about taking an individual approach, but and some of that individual approach may relate to autism-related features. So, for instance, kind of making sure that we're using the child's preferred communication, involving the parent in the conversation, because they may have a sense about how the child's behavior sort of translate in terms of what they're experiencing. But again, largely sort of management of health is kind of what those pediatricians and family doctors have been trained to do, and it's more encouraging them and feeling that they've got the backup support if they have questions, but really encouraging them to be fully engaged in providing a medical home for autistic kids. So a couple brief examples, some of the more common health conditions. So for example, sleep issues, super common among autistic kids. To be honest, very common among all preschoolers, and then perhaps a little less common sort of over the age span, but certainly this is one of the more common concerns that a parent might bring to any physician, regardless of whether their child has a diagnosis of autism. It's interesting that sleep issues tend to follow a very similar developmental pattern as in other kids. So preschoolers tend to have difficulty falling and staying asleep because they may, sort of have certain things when they fall asleep, like the light on or music on, that can't be reproduced when they wake up because someone's turned the light off, or they're used to their parent falling asleep kind of alongside them, and then sort of figuring out how to sort of kind of start to scale that back, because again, that can't be reproduced unless the parent's there for the whole night. Similarly, kind of autistic teens are often staying up too late and not getting enough sleep because they're online or gaming. So they sort of end up in a different time zone. They have kind of an issue with sleep phase that also needs to be addressed. We know that sleep problems may worsen kind of emotional health and therefore behavior, and contribute to family stress. The basic principles of working on establishing healthy sleep are pretty universal. So establishing a regular sleep routine, kind of addressing these sleep onset associations like sleeping alongside, and sort of, for instance, working with the parent to kind of remove themselves from the bed and maybe sit alongside and then sort of move towards out of the room, and critically really involving the parents in the problem solving, in most cases actually leads to very significant improvement. We recognize that there may be other kind of medical factors, like sort of that contribute to snoring, for instance, kind of obstructive symptoms that need to be addressed. There are some kids that benefit from being on melatonin to kind of reduce the amount of time it takes them to fall asleep. But honestly, for the vast majority of children, this isn't extremely complicated and something that that community physicians can manage. Again, sometimes with just a little bit of coaching and an opportunity to talk about kids they're seeing. Likewise, gastrointestinal complaints are really common. Most common is constipation. Often related to diet and food preferences, and the general management is largely similar as in other kids. Often attention to diet. Sometimes constipation needs medical management. Our go-to is Restoralax or Peg Flakes, because it's inert, so generally not associated with side effects. Certainly some kids who need to see a specialist, but those are decisions that community physicians can make as well. And then, we're fortunate to have like a structured continuing education approach called ECHO Autism. So ECHO stands for Extension of Community Health Outcomes. It's like it was Zoom meetings before Zoom was the thing to do. So it's a pretty simple format where you pull together a kind of a hub team or kind of a small group of specialists. They may be people that work together in a clinic, or they may be people that sort of are colleagues and bring complementary expertise. And then sort of people in community practices. And depending sort of what the focus of ECHO is, it could be physicians, it could be educators or rehab therapists. A lot of the ECHOs, just because of how ECHO was originally conceived, is focused on healthcare. So the core ECHO Autism is largely focused on management of physical health and emotional health, although there's increasingly emphasis on diagnosis as well. And again, it gives an opportunity for the specialists as well as the community partners to get together periodically, and for the community partners to talk about kids that they're seeing. One of the really nice benefits of it is, rather than a traditional telehealth consultation, it's much more of a community of practice. So rather than the specialist working with an individual clinician, you may have 30 or 40 clinicians online, and each week they kind of take turns talking about kids that they're seeing, and there's a real emphasis on their community colleagues asking questions and providing input into management. And I think my personal experience is I often learn as much through talking about other kids that people are seeing and sort of kind of challenging myself to kind of brainstorm about what might be helpful, so that continuous process of thinking about a range of diverse healthcare challenges, I think ensures that kind of ongoing learning, and then it also sort of strengthens the relationships between the specialty team and the community providers. In terms of healthcare, it's important to be aware that there are a number of accessible, kind of no-cost online resources. For instance, Autism Care Network, supported by Autism Speaks, has a number of excellent toolkits, for both families and clinicians, that provide a lot of practical information that can really empower parents to manage these issues and work with their clinicians to come up with some practical strategies. So it is an ongoing process. I mean, I have to acknowledge that that it's not easy for pediatricians taking on this work. We have a real challenge around primary care in our country. Certainly in Alberta, there are some infants that don't see a physician at all the first year of life, and so it's difficult finding a family doctor, whether you're a newborn or an 8-year-old or a 54-year-old. Even if you don't have sort of identified health or developmental health needs. So if you're a family of an autistic child, finding a family doctor or pediatrician is not an easy process. And a lot of these family docs and pediatricians are pretty tapped out with the work that we're doing. So it is really important that we make their jobs as easy as possible, and that they know they have a direct line of communication with us. But I've been really, it's been incredibly gratifying to see the number of community physicians that have stepped up to take this kind of advanced practice role. Ultimately, just to kind of wrap up this part of the presentation, and looking forward to some discussion, what do autistic kids need for healthcare? Well, they need kind of what all people need in terms of their healthcare. They need access to primary care and a medical home, like a physician who actually takes responsibility for their health as a whole. Providing checkups, referrals as needed, working with specialists, kind of being the go-to health professional that families can approach regardless of what their concerns are. Taking an active role in holistic care in terms of physical and mental health, and also thinking about other aspects of health and well-being, engagement and community involvement and recreation, kind of thinking about transition and kind of post-secondary, and making sure that it's a proactive process of working with parents. So there's no question that having this kind of medical home and that kind of ongoing relationship with a physician is really important. I haven't talked about it in the presentation, but clearly physicians have an important role in thinking about how to provide a welcoming environment in their office. So sort of both the physical environment and the way the staff kind of interacts with families. And there's certainly an element of universal design here. Like it doesn't have to be like there's like kind of a way for autistic kids and a way for other kids. I mean, certainly thinking about sensory environment, thinking about kind of friendly, respectful interactions. I think there are lots of kids and families that will benefit from that. Fundamentally, sort of ensuring that families feel supported and respected, and sort of have access to this kind of support, and also making sure that we're not getting too preoccupied just in pediatric care, because autistic people are children and they grow up to be adults, and like all of us, they need to have primary care throughout their lifespan. And the limited data we have identifies that in the same way that autistic kids have higher rates of the broad spectrum of health issues, physical health and emotional health, that's equally true for adults. And that may not be related to the biology of autism per se. It's probably a bit more related to environmental context. And it's also an example of how a more holistic approach to health and thinking about opportunities for physical activity and recreation, I mean, it ultimately has a direct impact on physical health. You know, later risk for coronary artery disease and blood pressure, healthy living sort of has a really important relevance for health for all of us, including for autistic people. So that is all I have to say, other than to acknowledge and thank all the amazing people that I have an opportunity to work with day to day. This is really a national conversation at a number of levels. Stelios alluded to the current effort to create a national autism strategy. You know, a lot of things that I've talked about today are not so much kind of top down, but are really about working with our colleagues, kind of strategizing in our own communities, having kind of creating a respectful space where we really appreciate what different professionals bring to the table, and making sure that people are working to their scope of practice, and that families are at the center of it, and families feel that they do have access to healthcare, and that they're being asked about their preferences and priorities, and that they're seen as essential partners in the process. So thanks again to the PARC team for the opportunity to speak about this today, and I will stop sharing my slides and looking forward to your comments and questions. Thanks.
Thank you, Lonnie. A couple of questions have popped through the Q&A. So we have a question from Gita in Saskatchewan, who would love to hear more about the community stream training model, if you could. They mentioned that where they are in Saskatchewan, many general pediatricians are already engaged in the diagnostic process, and Saskatchewan funding isn't dependent on something like an ADOS being done. So I guess they're wondering, was completion of a training model a requirement for general pediatricians to engage in autism diagnostics in Alberta?
Yeah, it's a great question, and you know, part of the question is required by whom. So, you know, technically, it's within the scope of practice for psychologists and physicians, as well as for nurse practitioners with a particular area of practice, to kind of make DSM diagnoses. Where it becomes challenging is around families accessing services. So, so there are a few layers here. So first of all, like working at a specialty center, we don't want to be like the autism diagnosis police. Like it's unrealistic and unfair for us to be sort of creating restrictions on community physicians who want to take on this role. On the other hand, there are certain kind of standards both in assessment and reporting that need to be met, like both kind of theoretically for a quality diagnosis, but also more practically to ensure that the people, you know, kind of who are the gatekeepers for supports and services are seeing the information they're looking for in the reports. So again, we see this much more as a partnership. So there are some community pediatricians who have had this role in Alberta as well, and have actually done really well with it. I think the feedback we get from a lot of the community pediatricians is that they would like to work independently, but they actually value the opportunity to get some structured training, and they remind us to be kind of very practical about it. So like, it's not only about talking about the DSM and like the nuances of it, interactive assessment, but it is actually talking about like what needs to go into a report. Like, how do you describe these features? What's the right level of detail information? And also it's very helpful to give like lists of supports and services, including web links for partners like Autism Edmonton, so they don't have to sort of pull that together on their own. So we've shifted from having most of those assessments go through our centralized intake to really saying, you know, to our community colleagues, like, you know, take these referrals, see your kids, but we do offer this kind of training. There's no cost involved. Like we provide that sort of ongoing support through ECHO, and continue to think about sort of how to expand it. So I think this is quite variable across the country. I think we have a lot to learn by actually working together across provinces. And again, I think we can do that within the framework of a national autism strategy, but we can also do this as colleagues now. And again, I'm excited that Mel Penner, it now has sort of a project where she's evaluating some of this in at least some of the provinces, and I think that will help move us along as well. I feel like we need to be working together more closely, because there's a lot of troubleshooting and practical challenges that so rather than each of us reinventing the wheel, it's great actually having this conversation. I'd love to follow up with you about this another time.
Okay, awesome. Thank you for the answer, Lonnie. Thank you for the question, Geeta. I'll move on to the next question / comment from Marg. Thank you, Marg, in advance. This is some good food for thought here. Is it time for us to advocate for a cross-Canada early years or Head Start type of program where any child not meeting developmental milestones gets seen, has an initial screening, and immediately gains access to programs while simultaneously assessing their needs? Then if a greater diagnostic specificity is needed, that can happen in tandem with intervention. Ideally, this could be a direct and seamless transition into school. Canada needs to be a leader in such an approach, and it should be available to all.
Yeah. So thanks, Mark. I mean, that was beautifully articulated, and I think you've kind of really hit the nail on the head. That we need to recognize that there are support and service needs that are, kind of evolve sort of through age and development, and may not be like exactly timed. There's an issue of accessing diagnosis, but the truth is there are kids whose kind of developmental needs may not necessarily imply a categorical diagnosis at an early stage. And we need to be able to provide those supports and services sort of kind of as the functional needs emerge, and then sort of deal with the diagnostic issues in parallel, exactly like you've said. I mean, the truth is a lot of supports and services are based on functional needs rather than sort of diagnosis anyway. So having that kind of flexible and multi-layered and sort of kind of like kind of continuous approach, I think is absolutely needed. I think that does take some of the pressure off the diagnostic system and also off of families, because there isn't this sort of like huge bottleneck and sort of like kind of barrier to accessing these kinds of services because the kids can't get a diagnosis. It's certainly a much more equitable approach as well. So I think that's really an excellent recommendation. It kind of speaks a little bit to Terry's comment as well.
Yeah, well, I mean, that's a perfect segue if we want to move over to Terry's next question. First of all,
Yeah.
thanking you for the thoughtful and holistic presentation. So Terry asks, do you think a family health team type of model would ever be feasible in pediatrics, as in a team-based approach with allied health?
Yeah, so I think my short answer is yes. Like I'm a bit humbled having you on the line. I mean, Terry, do you feel comfortable like kind of commenting to the group what the family health team approach is? And then I'm happy to weigh in a bit further about sort of how this might align with the kinds of concepts we're talking about today.
I'm just gonna hopefully ask to unmute so she can actually speak. Let me just.
Oh, okay.
There you go, Terry.
Lorna, thank you so much, because I was so excited to see Lonnie, and I was trying to say so good to see you at the beginning, and then I couldn't because Anna, I was muted. That's
My
okay.
bad, I'm sorry.
No, well, I'm thinking like really in terms of like primary care model in the US, there's sorry, in Ontario rather, and I'm sure elsewhere is that family physicians agree to roster essentially. So rather than kind of billing for one-off consultation for every patient they see, they have a certain expectation of seeing a certain kind of population of people, and then they will work with. Then they can have social workers and like pediatric consultants and psychiatry consultants that are based in their teams. And when I just think about the psychosocial needs of kids and their families, it just always seemed like such a great model for pediatrics, but it involves really like government investment in a different funding approach and different organizations.
Yeah, no, that's super helpful, Terry. I mean, in Alberta, we have primary care networks that are kind of very similar, where the physicians, like the compensation model is based on patient panels, and they are working in more of a multidisciplinary setting. I think what you're recommending is like absolutely fundamental from shifting from this kind of siloed approach to a medical home, because the medical home, as you're talking about, isn't actually only about a physician. It is actually being able to access like dietitian support, OT support. I mean, and some of this is available kind of like through autism specific services, but to kind of be able to achieve the kind of approach that Marg is describing, it also needs to be embedded within the primary care system. not having access to those supports is also a huge barrier for pediatricians looking to become involved in diagnosis. They look at the kinds of supports we have in terms of the nurses doing some file reviews or having a social worker meet with the family after the diagnosis. And they find it a bit overwhelming because they feel they need to own all of those tasks. So being able to work in a multidisciplinary setting within primary care, I think makes a lot of what we're talking about today, including involvement of community physicians in diagnosis, a lot more feasible. And of course, a better experience for families as well, because they're being able to access that multidisciplinary perspective that I think is actually really positive and helpful. So no, thanks, Terry.
Thanks for chiming in, Terry. We can blame Lonnie for putting you on the spot to actually have to unmute there. So I noticed we're coming up on the end of our time. Maybe I will just transition over to one of the questions that was sent in advance when this person registered. So maybe just a quick reflection, Lonnie, on the role of autistic people consulting on these types of programs and models.
Yeah, thank you. So you saved me. That would have been a huge omission, sort of not to suggest. Absolutely having autistic people with lived experience sort of be able to be really sort of part of the core leadership team in terms of describing these kind of developing and implementing these clinic models. And then also want to acknowledge that there are autistic healthcare providers that bring a real kind of dual perspective in thinking about kind of what's needed and what is actually going to be efficient. It's a bit of a side note, but I think often those autistic healthcare providers feel a bit marginalized and don't necessarily feel safe to kind of disclose their diagnosis. We need to create that sort of safe and welcoming space because they have, a really unique and valuable perspective to offer here. But again, not only autistic healthcare professionals, but other autistic people, and of course parents as well. But certainly thinking about what autistic people experience sort of in the pediatric care system and also their needs within the adult healthcare system, that is absolutely an essential component. So thank you for bringing that up.
Well, I will thank the person that sent in that question in advance. So we'll spread that thanks around. I want to thank everybody for joining us. I want to especially thank Lonnie for the really interesting and informative presentation. Thanks again, Lonnie. We really appreciate it.